Thank you, Dowin. Thank you, Elizabeth, and thank you, Joel, for allowing me to share some time with you all this afternoon. I was running around, so I'm going to give you a second to stand up if you need to. I don't know what has been in this room for the last 3 hours, but I know I was running around, so maybe you guys you weren't. But if you need to stand, you go ahead before I get into this mental gymnastics I'm going to ask you to do.
We just had a break. So.
Oh, good, good. All right, so you're going to sleep then, I guess. Yeah. So what my goal today in our conversation, and it is going to be a conversation, and I do speak fast, and I want to ask you to kind of keep up with that pace, is that I'm going to discuss research and ethical challenges sort of related to this notion of diversity and inclusion. I want to present for us a deliberative framework to think about ethics decisions or policy making in this realm. So we're going to work through it together for the case. And then at the end, I hope that I've equipped you with some tools for ethical justification. So the bias for me is I think that when we make decisions, we should be able to justify them. I might disagree with you. And in our present society, that is what's happening, that we don't know how to discuss disagreements. And so we have polarized views and we don't talk to one another. So many of us might have different views, but sometimes we don't have the ability to share them. What I would like you to do at the end of this talk is to have a process by which you go through when you face a challenge, be able to justify it, and then present that justification. Now, there's no right or wrong, although you might feel there is a right or wrong, but someone else might have a disagreement, and that's going to be okay. So we're going to have this notion that there's ethical plurality because there is moral pluralism in many of our spheres, and in medicine that is the case most of the time. So diversity and inclusion is something that's been championed for the last 10 years, and there are people in this room who have led that championing in our specialty. And I think we have this vision that it's going to be a great environment where we have patients and providers who come from different backgrounds. We're going to work together well in teams, and we're all going to be happy. Right? We champion it as a societal good that needs to be moved forward. And when you think about that, right, that makes sense from an ethical standpoint. I'm the chair of the ethics committee for SAEM. I've been that for the last 3 years. And we think about, well, there's a notion of social justice that underpins this notion towards inclusion, or this progress towards inclusion and diversity. That there are people in this country particularly, we have a history of racism, people have been disadvantaged in many ways, and that as we move towards a society, as we move forward as a society, we want to bring them forward, right? So we have pipeline programs, we have affirmative action in many realms, right? So there is a social justice notion that people should be, who were previously disadvantaged, should now have some benefits to get into a life where they want to be flourishing. Right? So their notions of flourishing should be advantaged. And the historical sort of problems that we've had in this society should be remedied. From a human rights perspective, we think everybody has rights, right? And this is the mantra in transnational organizations, right? That there's rights of there's human rights, there's women's rights, there's reproductive rights, there's the rights of the unborn. So we all have these rights. And what ends up happening, and this is what I said I'm going to do a little bit of mental gymnastics, is that we talk a lot about rights, but sometimes we forget about the duties that are then imposed upon the other person in that relationship, right? So we all want to have rights to do everything, but sometimes that causes constraints or obligations upon others who may or may not be willing to take that on. And that leads to ethical conflict. And practically, in terms of diversity and inclusion, right, there's a lot of empirical evidence for there being many benefits from the patient perspective and from the provider perspective. So, for example, there's a pointer here? Yeah, right. So if you think about increased diversity in the health professions, right, we know that leads towards, we can work through this, but it leads towards more people from disadvantaged backgrounds getting to the profession. And we know from a lot of data, national data, that then they likely serve in more underserved communities, and that community's health then improves, right? They have improved health outcomes through more access, improved quality of care. At the same time, when we have more people from disadvantaged backgrounds coming in, there's greater trust in the healthcare system, right? That also then cycles back to improve access and care. They're more likely to come to present to the emergency department or to the healthcare system. Improves quality of care because these individuals know the value systems that they come from, and then improved health outcomes. Or here, we have greater advocacy, right? So in diversity and inclusion has been championed by people who have been disadvantaged, or their groups, right? The groups they come from, the backgrounds have been disadvantaged. So again, that leads to improved access for that community, improved quality of care, improved health outcomes. The other thing that happens, and I'm going to talk about this today a little bit, is that we have more concordance between the background of the provider and the patient, right? Racially, ethnically, linguistically, and otherwise. And that leads to more effective communication, more stable healthcare relationships, and that again cycles back to improved quality of care and health outcomes. So we know this. It's not some just a model that we'd like to have this or it's aspirational. We know data, we know studies after studies show that there is data behind this, that this happens. It improves patient and provider patient outcomes. From the provider level, we also know this, right? That as you have more of a diverse workforce, you have a more tolerant or maybe welcoming, but that might not be the case, work environment. We know there's increased productivity and satisfaction within that healthcare system. So if you look at some of the companies that we talk about, they note that, right? They do job satisfaction surveys every year. They found that as they have increased diverse people in that job workforce, that leads to improved satisfaction with their jobs. And then there's also some fiscal productivity that increases. And we know people, and this is in healthcare, we know this, that people are less likely to leave that job or leave the profession totally, right? This is more of a tangential benefit that we have a little less data on, but we do believe that there's increased knowledge about the other, and the other being the other group, the non-majority group, whatever it might be, right? So that leads to hopefully some improved cross-cultural communication skills, both from the patient perspective and the staff perspective. All right, so many years ago, I wrote this paper. I was a resident, and I was behind this championing of diversity and inclusion. I thought this was a great thing, that we just have to adopt 3 principles. That everything comes down to 3. That's a magic number, and all of a sudden we're going to have a great environment, right? That we just have to sort of acknowledge people's culture. We have to respect cultural differences, and then minimize any negative consequences of that difference. That's it. Solution. We're done. Move on. And as I moved up in my career, I thought about how that plays out in the healthcare environment. Right? When you're trying to make decisions about who to hire, is there an ideal candidate that the job description is written for already, subconsciously, and that other people come from different backgrounds, they're not going to have the same chance to get that job, right? Or when you create policies for example, at our own institution, we had policies for many years on maternity leave, but nothing on paternity leave. Some people are at the institution that I was before. I worked a shift at 11 p.m. when my child was born at 3:45. Right? In the ED, you can't get out. No one's going to cover you. So this happened twice at my previous institution. So in any case, right, there was some policies, but it didn't cut exactly the same way based on where you're from. And so I kind of looked at some of the data around. That's a policy issue, but about what the data is of people in the healthcare environments and how they document experience of discrimination from the minority perspective. So look at this study here in Massachusetts, right? About 500 physicians in Massachusetts oversampled for international graduates and minorities. 2/3 of them report discrimination at their workplace currently. Right? This is I think 7 years ago. And then if you look at these groups, right, international graduates or minorities, you see the high numbers, almost half of them. If you think about a national sample, this is from one of my mentors, Marcella Nunez-Smith at Yale. The national sample, you found that 71% of African Americans describe discrimination over their career, 45% of Asians. This is not colored because it's okay, but it's just less than these people. And then if you look at the currently, still high numbers, 59%, 39%. Right? So we're moving towards more diverse workforce. We want to have a more inclusive environment, but people are paying the price in some sort of way. Right? If you look at just U.S. medical schools faculty there, so academic places, still, right? We have a lot of programs for URM, right? Underrepresented minorities. But if half of them are saying that they feel discriminated against in their career, what's the benefit of that program? What's happening? You're bringing them into an environment where they are having adverse experiences, right? So the phenomenon was yes, we have this nice picture of what diversity and inclusion will lead to, but largely the negative consequences of that we don't talk about or even research, right? There are a few studies out there. And I take an ethics perspective because I think we have to understand the other. What's happening, right? What are the obligations that you're mandating, quote unquote, and soft mandating upon the institution? And can they affect that change? So from theory to practice, right, I wrote that paper as a resident, and when I went to practice, there was a big gap between what was theoretically, conceptually great, what we all championed when we talked about it at that table to make decisions, and what was happening on the ground, the experiences of people at the ground level, right? And that gap, I think, led, for me, at least a lot of confusion ethically, right? That sometimes we will champion something and we think it's ethically robust, and we ignore the other side. And so today I'm going to kind of present to you near the end some of the other side, so we can understand what happens when you want that accommodation policy in place. What's going in the mind of those decision makers to accommodate, not accommodate. I'm going to have you think about that, right? So I initially thought we should do this as I do when I teach this to my ethics fellows at the University of Chicago. We actually have a debate. We set up pro and con, and you got to go. And you got to argue. It doesn't matter what you think. You got to argue the side, right? Because you have to get in the head of the other person that's making the decision. Obviously, this is not the setup to do that, but I think this is an exercise that we all have to do to see the other. And that's part and parcel of bringing forth diversity and inclusion. Okay, so let me just give you an example. Recently, let me kind of give you the setting of what's happening conceptually right now. Okay, so I am. I don't know if many of you know, but recently under President Trump, they opened in the HHS. They opened an office of religion and what's the title? Religion and conscience, right? And there was an open comment period, and I was asked to opine on that from a policy perspective from people in the government. And there's a debate there, right, where the pendulum is. So the debate is this: that we have from the patient perspective. For example, say about concordance, right? That people can express a preference or a need. I want to see a provider from this background or from this cultural background, religious background, ethnic background. And that puts upon physicians, or in this case, the healthcare system, a duty to provide that, right? That office is flipping it. They're saying, okay, well, look, physicians have a preference of how they want to practice medicine. They want to be providing some sort of services and not others, right? And that now leads to some sort of societal ramifications of how do we deal with that. The first part, when we think about individual preference and need, this has been talked about a lot, right? And I'm going to talk about it in the case today. But the second part, well, how do we obligate MDs, right, who have living out in medicine some notion of what brought them to medicine to provide something for society they don't want to do? Is that ethically or politically justifiable or not? Right? So it flips. So we had, historically, we had Bush on one side, we had Obama on the other side, we have Trump back. So the pendulum keeps on swinging back and forth. And in between all that are patients and providers, right, at the ground level who have to deal with, well, today we're talking about patients' rights, tomorrow we're talking about providers' mandates, right, about what they can do, or obligations to do this or not obligations to do that. And your workforce sometimes sees that conflict in provision of care, where someone says, well, I look at this view, and the other says, no, I look at that view. So it's not something that's just typically theoretical. This is occurring now. And there was an open comment period that all of us should be thinking about. How do we comment on this? Because it's going to become policy that we have to then, if there's a legal protection for some people, then we're going to have to think about how we are going to deal with that at the bedside. Okay, so moving forth, now this is us, emergency medicine. I want you to take a minute and absorb this picture. It's actually, it was painted by the husband of a patient in the ED in the 1940s, I believe, from a minority community, about her experience in the ED. I think 60 years on, I think our patients would resonate with this as well, right? So I'm not going to call out what you see. Actually, maybe I should. So do other 2, 3 things that strike people in this room from this picture that you think hold true today? Yeah, 79% of the workforce is still white male in the ED. Anything else? Examined, yeah. Cared for and examined. Anything else? One more thing? Yeah, well, that's, I think that metaphor holds true today, right? The power differential, right? Some people in my class, they talk about the raven, right? Death, people filming. So we have a policy we have to develop about people filming us now in the ED with their iPhones. Like, how do we deal with that? All right. So here's the case that we're going to work through, and as I said at the end, we're going to flip the script in a second. So you're going to need some participation shortly. So here's the case, and some of you have seen a version of this case. I've seen me lecture before. But anyway, we have a 30-something Arab woman who comes to the ED with headache infusion. She was jet skiing with her husband in Lake Michigan. some sort of, some question of LOC, but no nausea, vomiting, no weakness, has a moderate headache. Vital signs are largely stable, safe from tachycardia. And this is a nursing triage note, so she makes the comment that she would like. In her case, she wants a like provider, which she means by the same sex provider. Okay? And the question for us, and this is we're going to raise our hands and then we're going to work through this ethical justification notion, is, assuming you're working in a single pod ED, would you try to accommodate this request? Yes or no? So why don't we raise our hands? And we're talking in a few minutes, so just get ready, because now I'm going to start, your hands are going to move now, then your mouth's going to move in a few minutes, yeah? Huh? So for example, at this case, you have sort of area A, area B, area C, right? So there's multiple sort of different pathways people go in. Might think about it by ESI level. So you're the single physician in that pod. But there are other physicians, yeah. No one asks who you are, by the way, right? Because you could be a female yourself, and then there's no question. But in any case, would you try to accommodate? Can we raise our hands? Yes? Okay, all right. So if the patient was this patient, she came to your ED and she said she wanted to be seen by the chief of service only, and your hospital administrator said, that's good, call him from home. Would you try to call that person from home? Yes or no? A few hands. Come on, raise your hand if you're sure, yeah? Yeah? All right, okay. All right, if Cornell West came to you, I trained at the University of Rochester. He was at Cornell. He's not at Cornell, but at that time I had the slide up. So if he came and said, I want to see my brother, I don't want to see anybody else, just my brother, who would accommodate that request? Interesting, okay. And if this man came to your ED and the nursing said that he wants to be seen by a white male, who would accommodate that request? Okay, all right. So we're going to come back to this in a second, right? So we just noticed in the hands of the room, right, there were some people you were saying that we were more likely, or the hands went up more for the Arab female, less hands went up for the chief, no hands went up for the African American full professor, and and someone who I don't know, just some picture from Google Images. But we can presume or think about him in a certain way. So this is where sort of ethics matters, right? So if you're thinking about this philosophically, they're the similar requests. They're about someone from their background that they want to see, right? And this creating some sort of constraints and potentially will create some obligations if you think it's justifiable upon the recipient of that request. And so here's the framework that I think we should all think about. So first you have to state the issue of the question, what is being asked, or what's the ethical question here, right, about accommodation. Then you think about, okay, well, what are we going to clarify about the terms? What's actually being asked about us, from us, right? What data is there? What is the current practice about, in this case, accommodation or evidence for why we should accommodate? Are there any ambiguities in this case that are not present in other cases? Who are the relevant stakeholders, right? In this case, patient provider, but are there other stakeholders who have to think about when you want to accommodate or not accommodate this request? And then we think about, okay, what ethical principles do we have in our toolkit to bring forth to make an argument, a justificatory argument about whether or not to accommodate? So you do all that and you come up with some sort of idea, okay, well, based on this, do I have to reformulate the question? So the question is not about accommodating a patient, it's about something else. Oftentimes you don't have to reformulate the question, then you come up with solutions. And the idea is that you have to come up with, and when I teach for ethics fellows, multiple solutions, right? So it might be someone's mentioning maybe we find someone else from home to come in, you have someone else from another pod, or no, we don't do it. This is not what you get in the ED. You get the provider, we're all board certified physicians. Really in step 5, you think about the implications and the constraints upon that. So if you have some notion of several solutions, which ones have some practical constraints so that they're not a solution in our shop, in our context? And what are the implications? Do we do this for one person or for one group, or are you going to do it for all? So what are the implications you have to think about? And then you decide a solution. In the end, right, you continuously reevaluate your solution because we know when we started off that there were several options, not one, right? Someone might disagree with you. You might be the chief today and be able to do it. Tomorrow there might be someone else. we have an on-balance situation, right? Today, in our context, we can do this. We have deaf interpreters, so, right? But tomorrow, you might have someone from some other group, and we don't have that. So what do you do then, right? Do you provide everybody with interpreters who wants it? What lengths are we going to go to? And then, do we have to make compromises on our decision? So we would like to do something, but we can't, right? All right. So here we go. So I said you're going to raise your hands, right? And some of you sort of said we would accommodate an Arab female. So I'm going to ask you to justify your position. So should we accommodate this request and why? I need a volunteer to say why and go through that. Who raised their hand before? Jeff.
So I guess the reason that I was willing to accommodate her request was from a religious perspective, on the assumption that she specifically is looking for a female and is religiously prohibited against having a male touch her.
Okay. All right. I use the term Arab female, by the way. But that's good.
You didn't actually specify religious, and I made an assumption.
Right.
And that was
right? No, I'm just pointing it out.
No, it's true.
Right.
I'm glad you pointed it out. Yeah. Thank you.
Go ahead.
So we have a large Orthodox Jewish population, and I'm Jewish, so I feel connected to the idea of I know what the rules are. And the rules don't prevent you from being taken care of by a cross-gender physician. There's actually, at least in Judaism, and I believe in the Muslim faith as well, there's a clear delineation that life over that. And so there isn't any, even if it's a perception, it's not a reality by any rabbi that I've ever met. But what is interesting, when patients won't look you in the eye, or at least they won't. There are lots of other things, but there's no reason not to.
So you're saying, to answer this question?
Yes, I would not accommodate it.
You would not accommodate
No,
it because you believe. Go ahead.
No, go ahead.
No, so you're saying that you think that there are other options available, and because of that, you wouldn't accommodate.
I think that in a healthcare setting, the healthcare is the priority, and the gender of the physician is a non-entity. That's not the relationship. The relationship is in the healthcare delivery, and that has to be the prevailing relationship in order to protect the integrity of the healthcare delivery.
Okay, thank you. Other thoughts? We'll go ahead. And then next to you.
So,
all right.
I'm an accommodating person, and
I like to think so. I know a little bit about you.
Yes, and it's not just about the religion when females ask for special accommodation. It's how comfortable it makes them feel in the emergency department, and that will maintain a good patient-doctor relationship for me. So the same thing with the 19-year-old young woman of whatever religion, race, asked to be seen by me. I'm accommodating. I'm thinking about my 15-year-old child who would be more comfortable. So for that reason, it's more the comfort level and maintaining the relationship with the patient. If I can't, I can't. If it's a crashing emergency and I can't, I can't. Yeah. But if it's not a crashing emergency, I'm very accommodating.
But that's the difference, though, is that this is implying there's
different story.
No, but this is the implication, though, is that she's asking, and this is we're making assumption, but we're assuming that she's not asking, she's asking for some either comfort level or a religious level reason, but not because she's racist or biased, and that for me is the crux of this, right? Because I agree with you that but it's like the sexual assault victim who comes in and would prefer to have me take care of her because she's been assaulted. I'm going to try to accommodate that because her request is not about her, being, again, biased or racist, but it's because she's been in a very difficult situation and she would like to be cared for by someone who she will have a better relationship with. But that's the distinction that I make, and I'm not sure if that's correct or not, but that's how I look at it.
So I think that's very interesting, and I'm glad you brought that up because we're going to talk about that, or at least I'm going to comment on that in a second, in a few slides. So one more, that'll be 5, I think. Yeah, go ahead.
So you had her in a burqa on her jet ski, or a burqa bikini, or whatever they're called. I'm sure that I am getting it wrong. But the other challenge, I think, is I've had Muslim patients who are uncomfortable unveiling
Yeah.
if there is a male in the room,
Right.
even if their husband or father or a male family member is present.
Yeah.
And you are describing someone who needs a good neuro exam and a good C-spine exam. And I would accommodate her again because I need to do a good exam, and I've actually seen patients decline portions of the exam because they don't feel comfortable with the provider, and that is a danger to their health.
Very good. So there's 5, so I'm going to kind of repeat what I heard in the room, and you might have others. We're going to go through this case, and we're going to have just some discussion. But just for the sake of moving forward. So one was, one was an assumption of someone's sort of background, right, potentially religious. I didn't use that term specifically for that reason, but we'll go forth and you'll find out who she is or isn't. But there's a religious notion, so I would accommodate. On the same row as you, someone said, well, if she has a racist notion, right, then I wouldn't want to do that because I don't want to continue sort of pervasive racial ideas and attitudes with my patient population. What?
It's that I'm not accepting abuse.
I'm not, okay. No, behind you.
I'm talking about
Yeah.
the same thing.
Yeah.
Is that I'm not accepting abuse from the patient in that.
All right. Okay. Right. So the other case, right? But in this case, I think if I heard correctly, well, as I said, if you think about the value that's being asked about, or the request that's being made, it's a similar request. There might be reasons behind it. Someone was saying religious reasons, maybe I'll accommodate. Someone's saying if there are other reasons, maybe I have to think about it more. Okay? Or if one person said, well, I want to accommodate for patient care. There were 2 sort of ideas, right? That maybe leads to better patient care, maybe even not patient care here, maybe long-term wise, that incident would. And then another person sort of said, well, maybe we shouldn't think about the provider as someone who has, or the dominant thing that we should think about as the healthcare provider is a provider of certain emergency medicine, right? That's the dominant identity. That's the identity we should put forth. So when we think about these sorts of accommodations or policies around this, we have to think about that. What are we turning that physician, that profession into? Something like that. So thinking about this, so let's move towards that system, right? So we're going to work through this example. So in terms of considerations, right, ethically, and this is, I'm not a principalist, by the way, so I don't teach principalism to my ethics fellows, but just this is what everybody sort of goes back to, and I'm going to just name this, we'll use this for a second. If you think about our respect for autonomy that we're taught in medical school, right, that individuals have an ability, or the core essential identity of an individual is their ability to make decisions, right? Their cognitive functions, and that we should respect that notion. Healthcare, that means respect for autonomous choice. Now, there's strong and weak versions of that, but you might say, okay, if someone's making a choice, we should try to accommodate that because they're acting out of the essential nature of who they are, okay? In terms of social justice, you might say, well, if I'm thinking about the community that I live in, now there might be many different groups in that community, and if I want to start doing things for one population, can I provide the same level of comfort in this case to another population? So you might make an argument that maybe this will lead to more variability and disparities in care than we can accept and tolerate, right? So we shouldn't do that. If you think about respect for person, which grew out or sort of underpins autonomous choice in a second, we're respecting this person's values. There's a stated value system. It might be religious. It might be something else. And so we should try to respect that if we can. In terms of non-maleficence, I'll share some of the slides here in a second. There might be possible harm to the patient, right, if we were to sort of not accommodate and then do some peripheral exam that's not full, right? So there might be outcomes issues here. Or she feels so violated in that examination room that she won't come back the next time she has some issue, right? So there might be some possible harm that accrues downstream. Here are some empirical data. So the patient was a Muslim. I took a case from Lake Michigan. Yeah. Yeah. All right, very good. So 97 adult Muslims in Moss in Michigan. This is my own data. We found that 21% of them sort of delayed seeking health care, men and women. In the Muslim population in Chicago, we found that 53% delayed seeking care because they can find the same sex provider, right? So this is pervasive in that community. I did sample in mosques, so they're more religious, but that was true there. And this is some quotes from this work, from this data. So this is a patient who came to the ED, a female, who recollects her experience like that. She was being examined for a vaginal complaint. She said this is how she felt after that examination. This is another woman, this is an African-American woman, who said, I came to the ED wearing a hijab, blah, 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 all this stuff, and then, why do I have to always say I need this? Why can't they understand who I am when I come in like that, right? That I have to always advocate for myself. The burden's on me. They should understand something about me when I come in. This is her view. And then this was a Turkish patient in a rehab facility after a stroke. He said that I had daily dignities perpetrated upon me every day. And from his 2-month stay, he remembered this, that every day, every morning, right, that this is what I recall, that I was being washed by a female person every day. I couldn't do it myself, and that was horrible for me. So it affects them in ways that we might not account in statistics, but this is how their experience was. From the scriptural sources, you mentioned this. I'm not going to belabor this. If you want to talk more about it, we can. But there are scriptural bases for modesty notions, right, for both men and women. And there is, so this is from the Quran, this is from the Sunnah, so this is a prevailing value within the Islamic faith. And there are religious rulings around who you should seek, all right, in terms of physician, if all else is equal, again, if all else is equal, not urgency, not other things, right? So you should have same gender and then sort of faith after that. And that leads to some notions around what you can uncover between other people, or in front of other people. Can you be alone, and can you actually touch, right? So there are a lot of rulings around this that carry over, yeah.
How does that affect the other patients in the department?
What do you mean?
Like, so I think that's, I didn't know this, like I said, but I'm curious about the accommodations based on gender or anything else, like how do they affect the...
Right, so that's step 5. That's step 5, right? So step 5 is to think about the practical constraints and implications. We're still at step 2, and I'm gonna buzz through in the back, forward in a second, but step 2, wait a second, what happened? Step 2 is clarifying what's happening, right? So we have data on what happens to Muslim patients in this case, what they feel, so I'm giving you that data, right? Whereas current practice, we don't necessarily accommodate everybody in the room, right? Who are the stakeholders? Not just them, not just us, but maybe they're people, future patient care, right? And so then we have some other, so I'm just still here, but then you're now generating, do you have to reformulate the question? And in this case, there isn't. I'll finish soon. You move forward and say, okay, well, now I can generate possible solutions. Either I'm going to accommodate or not accommodate based on this request. What I know about it. What happens is sometimes you make assumptions about what people want, right? So I didn't say neo-Nazi on that white slide, right? I didn't say anything about that patient. I don't even know who he is. I just put some Google thing, right? Because I'm making an assumption. I have an unconscious bias of what that person, what their value system is, who they are, what they want. It could be that they don't actually, there could be someone who doesn't hold that value system today, right? But I've made assumptions. And so our own notion of what people are bringing in colors how we think about things. I think as an ethicist, we pause and get the relevant sort of data out there, what's going on, right? Or you might ask the patient about what's going on. But let's move forward, since you asked about the practical constraints. So, there are all these other issues that we have to think about. Who's in the room, right? I mean, who's in the ED? Well, how is it going to affect other patient care, right? That is not something you can ignore. I might want to accommodate, but I can't. Or I'm not going to call my chief in to work at a 2 a.m. shift because, Hillary Clinton shows up to my door. I might not do that. Maybe they want to come in, I don't know. It might be that the patient is dying in extremis, right? I might want to accommodate that, or their family members to do this, but I can't, right? If I don't code, in this case, if you look at the ethics literature, there's a case of a patient who died because they're a Muslim patient, who died, this is in the ED, because their family member wouldn't allow a non-gendered provider, a non-same-sex provider to see them. And they died in the ED because they said, they literally were going to assault the provider, right? We can't tolerate that, right? We can't tolerate that. We might need to get security, but my point is that this happens. Their notion is what I think is a little bit uncomfortable as an ethicist for me. That we, when we understand, just like in ethics, right, when someone makes a decision we want that we can understand, it doesn't go to the ethics committee. When someone suggests a preference that we can't understand or rationalize, it goes to the ethics committee. So if we believe, right, that we have an ability to fully understand that person's background and make a judgment about their background, their value system, right, I feel that we are doing a disservice to where we are epistemically in relation to them. That we don't actually have all that data. We don't have those experiences that colored me, right? Someone's racist. What happened in their life to make them racist, right? And will I be doing more harm when I want to change that? And is the ED encounter one where I want to do social justice and make you think about something else, right? Or am I causing harm to that person's value system? So I think, yeah, we're all in the bandwagon, we should be doing certain things, but it causes us to sort of make assumptions and even actually try to do things to people that I think can cause harm when we want to rectify a social problem in our ED. When they're coming to us, not for us some rectification about their value system, but provide good care. And can we do that without trying to impose upon them our belief structure, right? I truly believe that there is a challenge for us to overstep when we shouldn't. Just like chaplains shouldn't overstep talking about something that they're not qualified to, are we, and should be in the ED. So let me end here. So let's talk about, as I said, when I had all these great ideas when I was a resident, and then when I sit on these policy committees, I get very confused. So what is reasonable? Right? So when we're thinking about accommodation for patients, so the healthcare system I used to be at, even you guys know, we had a Japanese family clinic that worked, right? That was paid for by a car company. They wanted to do a Muslim family clinic and didn't work out, right? It didn't work out. And the question was, well, what is a reasonable accommodation? The Japanese family clinic, we had to sort of come up with different structures for appointment scheduling because they have a different cultural value. They want to see, they're provided 12 times a year for 6-minute visits. But if we're going to accommodate Muslim patients, we have to then think about having gendered staff in a certain way so people can come in, right? So what's reasonable to accommodate and what's not reasonable? Is that person who might be a neo-Nazi, is their value system reasonable to accommodate or not? And the law where's the burden there? What's reasonable? Right? What extent can we mandate a healthcare system to go for, to have to do? I'm ending, don't worry, I see. Right? And what is not accommodation ethically justifiable? So we know when we don't accommodate, at least the variabilities in care. Disparities in care is because of lack of accommodation in certain respects. Cultural value systems, linguistic, we have these data, or there might be data about deaf patients, I haven't looked into that. That when we don't accommodate a value system, it can lead to disparities in care. What are we willing to tolerate as a society? Because we can't do everything, right? We're not going to come up tomorrow and say we're going to have segregated hospitals in this society, right? And here is this other notion, right? So where's discrimination, right? So if a family, if a family or a patient encounter leads to a notion of perceived discrimination, and then they file a lawsuit, what happens to your bottom line at the hospital system? You're known in that community as a system that won't accommodate this value system. And as I've sat on some of these committees, that is actually an overarching concern for some people, right? Who might not be clinicians. But look, we can't have something come out in the press about this or that, the other thing. We're in a situation where if this goes out, we're going to have a problem in our market share. So do what you have to do, right? It doesn't matter. Do what you have to do so that they don't go out, right? They're the son or the husband of this newspaper's journal editor. Just go forth. Just do it. Right? Or you might have VIPs. This is my context. You might have VIPs who come in. So I think that when you sit on those committees, there is a notion of what the limits of accommodation are. So when you move from, as I said, when I thought about theory and practice, there's a lot of gray stuff happening. And at the end, what I want you to think about, as I said, right, is we might have a solution today for something. But if you go through the system, you might have come up with multiple solutions that you can enact tomorrow. And you have to constantly reevaluate whether that's practical for you. So yeah, maybe we're going to accommodate the Muslim woman who I said was Arab, right? But maybe tomorrow we have to accommodate the neo-Nazi who comes in the door. Maybe we have to, or maybe we should. Right? And maybe you might not want to, but it's ethically justifiable. Anyway, I will leave it there. I took too much time. I apologize. But thank you for bearing with me. Sure.
A couple questions while we switch presentation. Anyone have any questions for him? Or would like your question out?
Yes, sir.
So we often justify our behaviors or rationalize our behaviors. I was one that said I would choose to accommodate, and I'll accommodate in the situation for religion, but I'm not going to accommodate when I make the assumption that it's racist. So are you basically saying that any accommodation can be perceived as judgmental?
So an accommodation, the opposite end of that is discrimination. So something that you accommodate can be, or don't accommodate, can be seen as discrimination against them, right? Or if you accommodate, it could be, well, you're going to accommodate this person's value system. The rape victim comes in for an exam, but not the person whose husband is telling you that I don't want you to see my wife. Right? So that's my point, that there isn't a singular notion here that your framework will have both happen at the same time. And we need to understand the other side to make informed choices. I actually believe so, policies in this case. Right, that what's going to happen to the next person in the room who in that curtain is overhearing you doing this for them, not for me. All right. Thank you.
Thank you so much.
No problem.